Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be with you today, chairing this second session. I would like to thank Dr. Mohammed Ahmed and the organizing committee to give us this chance to be with you today. I'm delighted today to introduce the second session, Professor Sonja Moline. Sonja Moline, she is adjunct associate professor of dermatology at Queen's University in Kingston, Ontario, Canada. She's completed her training in dermatology and allergy at the Ludwig Maximilian University in Munich, in Germany. Dr. Moline is specialized as occupational dermatologist and member of the board directors of the German Society for Occupational Dermatology and the American Contact Dermatitis Society. She is also a counselor in the International Eczema Council. So that means the title will be Dilgocetinib, which is the new JAK inhibitor topical cream got FDA approved for chronic hand eczema. Professor Moline, the stage is yours. Thank you.
Thank you so much for the kind introduction. Good afternoon, dear ladies and gentlemen, dear colleagues. I'm very honored to be here with you today. Very honored to be here with you today. I hope you can hear me well. It is my pleasure to be here. You will see on the first slide that I have two affiliations, and this is due to the fact that I just recently moved back from Canada to Germany and started a new position at the Charité Hospital in Berlin 3 weeks ago. Today, we're talking about one of my favorite topics, chronic hand eczema. I do have some disclosures. Now, the objectives of this presentation are to first give you an introduction, an overview on chronic hand eczema. What are the few key things to keep in mind? Is there any new data, something to remember? Then we will talk about treatment guidelines. The most recent guidelines have been the European guideline and the German guideline. And then I will introduce you to the new treatment option for our patients with chronic hand eczema, Dilgocetinib cream. Well, hand eczema is quite a relevant disease. It's very frequent, and it comes with a high socioeconomic burden and also a big impact on the quality of life of our affected patients. It is very frequent, and very often patients move on from an acute or more acute hand eczema to a chronic course of the disease. And to be honest, most of the patients we will see already have chronic disease, because chronic hand eczema is defined as hand eczema for longer than 3 months or 2 or more relapses within a year. And this is almost everybody I see in clinic, I would say. It is a multifactorial disease and with many different clinical pictures. It is difficult to really say from looking at a hand eczema what is the main contributing etiological factor, and often we will see subtypes. Our patients are suffering a lot from their hand eczema due to the itch and due to the pain. So these are definitely things we want to address, and we also want any treatments we offer to address those and give fast relief. The burden of hand eczema is huge, particularly on the individual suffering from hand eczema, because we need our hands in our daily life for everything, for our social interactions, for our jobs, for every single task, almost every single task I would say that we do, we need our hands. And if the hands are sick and we can't use them, this impacts our well-being, it impacts our interactions with others, it impacts our families, and it really impacts our quality of life. Hand eczema is quite frequent, and there are some predisposing factors. You are aware of these, but I wanted to highlight some of them today. For example, atopic predisposition. So patients who had atopic dermatitis in their history are more prone to develop a chronic hand eczema. Another group that is very prone to develop hand eczema is everyone who works with their hands or is exposed to wet work or contact allergens at work. If we use our hands, we're at higher risk of developing eczema. Female patients report hand eczema. Thank you. Yeah. Thank you. I hope you can hear me well. So female patients report hand eczema more often than men. It has to some extent to do with the duties that female patients do more than male patients. Onset often in the 20s, but there's also pediatric patients that suffer from hand eczema, and then the onset can be around the age of 11. Very interesting, we know that smoking also can have an influence on the development of hand eczema. There's different subtypes, and usually classifications divide between the etiological subtypes and the clinical subtypes. These are the eight subtypes that are mentioned in the European guideline. It's relatively easy to remember. You have 4 etiological subtypes: irritant contact dermatitis, allergic contact dermatitis, atopic hand eczema, and protein contact dermatitis, the contact urticaria. The clinical subtypes, where we diagnose a subtype according to what the hands look like: a hyperkeratotic hand eczema, acute recurrent vesicular, then nummular hand eczema, and pulpitis. Very often, to be honest, in clinical practice, we see mixed forms. We see a mix of clinical subtypes overlapping, and the clinical picture may change over time. And sometimes we find that the initial trigger factor for the hand eczema of our patient changes over time, or we removed it and still the hand eczema continues. So I think it is important to keep in mind that hand eczema is very multifactorial and has many different phases, and the hand eczema can vary a lot between your patients and can look very differently. But what is important to keep in mind as well is there is a common denominator. Okay, I get scared. There's a common denominator between the different forms of hand eczema. They're based on several trigger factors, endogenous factors and exogenous factors contributing to it. And the 2 big things to keep in mind are inflammation of the skin and skin barrier defects, because this is what we also expect our treatments that we offer our patients to address in order to make the hand eczema go away. And then the exogenous triggers, most common are irritants, irritant exposure, then contact allergens, but also pathogens. And we're only learning more and more now about the role of the microbiome in chronic hand eczema. There's still a lot of unknowns around the pathophysiology or pathogenesis of chronic hand eczema, and it's like a big puzzle where we only know a few of the pieces yet. We know the barrier disruption plays a big role. We know the inflammation plays a big role. We also do understand a bit more today that different immune profiles and inflammatory signatures play a role for the different subtypes. But I think there's still much more we will need to know and have to learn in the future. What we know, for example, is that irritant contact dermatitis is more like innate immune system, Th1, Th17 profile. Allergic contact dermatitis, well, varies largely between the different allergens. For example, if you look at metals like nickel, it's Th1 and Th17, whereas rubbers or fragrances rather tend towards Th2 and Th22, more like an atopic hand eczema. So we have inflammation and barrier disruption. We want to address this. We know now that the JAK-STAT pathway certainly plays a role in the pathogenesis of hand eczema, and this is what we're hoping to address with our treatments. A few words on the diagnostic workup. So when you see a patient with chronic hand eczema, my first question that I ask myself always is it really hand eczema? Because there's so many other skin diseases that can mimic hand eczema, and some of them being quite common, like psoriasis on the hands or a fungal infection. So it all starts here. It all starts on the left side. You can see it with assessing is it hand eczema or not. Then a thorough history, because the history helps me to understand a bit what exposures is the patient exposed to. Is there irritant exposures? Do they wash their hands often? Do they have do they do a job where they are exposed to irritants or allergens? Then, if possible, we patch test, because we would like to confirm a contact sensitization. And you might have noticed that in the afternoon I'm giving another talk today on contact dermatitis and the multiple phases, or the different phases of contact dermatitis. For my talk this afternoon, I will be focusing a bit on exposure patterns, but also clinical patterns, how you can try to extrapolate from the clinical pattern of the contact dermatitis to the causing group of allergens, particularly in a situation where you might not be able to offer a patch test. On hand eczema, it would be favorable if we could do a patch test, because if there is a contact allergen, we would like to counsel on avoidance. Same with irritant exposure, we would like to recommend skin protection. We would like to understand endogenous factors like an atopic predisposition, because this tells me that my patient might be more prone to certain exposures, and then protein exposure if we're thinking protein contact dermatitis. After diagnosis, we want to speak about treatment. Just recently, 2022 and 2023, two guidelines have been published on the management of hand eczema. To the left, the European one, and to the right, the German one. I would like to introduce to you the recommendations, the treatment recommendations of the German guideline today. It differentiates between different severities of hand eczema. It has a stepwise approach. To the left in green, you see is basically step 0 is just dry skin, so no active hand eczema. Then in blue, mild hand eczema. In yellow, moderate to severe hand eczema. And step 3, really the persistent, moderate, and severe hand eczema forms very chronic or recurrent hand eczema. And usually, the different steps are an add-on. The next step is always an add-on to the previous measures. Very important, let's not forget about skincare measures. Let's not forget about avoidance of allergens where possible, and a reduction of trigger factors. No matter what treatment we're trying, I think this should be an important mainstay. Still, gold standard of the topical treatment are topical corticosteroids. You would choose the strength according to the severity of the hand eczema, and it makes sense. The more severe the hand eczema, the stronger the corticosteroid. For those patients who are very refractory or have atopic dermatitis, we can think about systemic treatments. Alitretinoin is a retinoid, is an oral retinoid that is licensed for severe chronic hand eczema that is not responsive to topical steroids. And the other options that are listed here, like for example, the biologics or the oral JAKs, come from the treatment of atopic dermatitis. So would be used in patients with in the circumstance of severe atopic hand dermatitis. A few words on treatment escalation. I basically mentioned it already. It is those patients with the very chronic and severe forms where we have tried everything else before in the pathway, and we notice in the topical treatment that we have to escalate. Now, what I would like to highlight is that I think it is a wonderful time for patients with eczema and also with hand eczema, because for the first time, we are able to offer innovative treatment options. Because what we have doing for a long time, for example, with topical steroids, was working to some extent, but was coming with certain problems or risks like potential risk of side effects, cutaneous atrophy, or barrier disruption in topical steroids in hand eczema. So clearly, we needed something else. We need something that we can offer. And I often was thinking, I would like a topical treatment option that I can offer to all my hand eczema patients in all different subtypes that will help with the inflammation and will also help with the barrier disruption. And it looks like someone has granted this wish because we do have delgocitinib cream now available. What is delgocitinib cream? Delgocitinib is a pan-JAK inhibitor. This is very special because it inhibits all members, all 4 members of the JAK family, JAK1, 2, 3, and also TYK2. And by doing this, addresses the inflammation in hand eczema. And there's also hints that it will address the barrier functions, or will help to restore the barrier, which is very important because we're dealing with a disease who is based on barrier disruption. Now, I would like to give you an introduction to the most recent and most relevant clinical trial results from the delgocitinib development program. Delta 1 and 2 are the 2 big phase 3
1
studies.
minute left.
I'm very sorry, I will have to go over time, and I hope you grant me some 5 extra minutes. Then Delta 3 and Delta 4s. Delta 1, 2, and 3. Delta 1 and 2 were 2 trials where delgocitinib cream was compared to cream vehicle over 16 weeks. Delta 3 was the open label extension trial where patients could be on open label delgocitinib depending on the severity of their hand eczema. Makes sense, if the hand eczema was great, they were not on treatment. If the hand eczema was flaring up, they would be on the treatment. And what are the results? Efficacy, safety is what we will be briefly talking about. In green, you see delgocitinib. In yellow, you see the cream vehicle. We're looking at HEXI 75 and HEXI 90. You all are familiar with the scores PASI and EASY. For hand eczema, we have the HEXI, which is the hand eczema severity index. And you can see that there's clearly a differentiation in the number of and the percentage of responders between delgocitinib and the vehicle. Same for the DLQI improvement in our patients. What matters the most to our patients is how they feel. Of course, I want to see an improvement of the hand eczema, but my patient wants to have less itch and wants to have less pain. And this is what you can see in the trial results. On the left, itch, on the right, pain. And it starts as early as on day 1. So the itch gets better with delgocitinib cream on day 1, and the pain gets better on day 3. This is what we have seen in the clinical trials. And this continues, this trend continues over the full 16 weeks of these trials. What about safety? Well, no safety signals compared to the cream vehicle. So we have not seen any of the side effects of interest that we are monitoring in our JAK inhibitors, and I think this is quite relevant and favorable. One of the first questions that came up is, okay, of course, we want a treatment that we can treat all hand eczema subtypes with, but does it really work well in all subtypes? And here's some data to answer that question. You can see over the different subtypes.
Thank you, Dr. Moulin, because we are over our agenda. We have another speaker to go also.
Okay.
Thank you, Professor.
Thank you so much.
Thank you, Moulin. So we'll keep the question to the end of the session. We'll move forward with Dr. Danny Thoma. He's a Boston University trained dermatologist and dermatological surgeon. He's well known in the laser therapy field, rejuvenation, and he is founder of the Skin Clinic in Beirut and most recently in Dubai. Please, the stage is yours to talk about laser as isotretinoin-sparing solution for acne management. The floor is yours.
Thank you very much. It's always a pleasure to be here at RADV. Thank you for inviting me again. Dr. Moulin, that was a very nice talk. You know, acne is the reason why I went into dermatology, so it's a passion of mine. I think it's a main course in the practice of every dermatologist in this audience. I'll be discussing tools from comedone extractors to expensive lasers, and I absolutely have no commercial conflict of interest in any of them. Just a quick overview of acne vulgaris. Of course, affects almost everybody at some point, with a prevalence up to 90% among adolescents, can manifest as early as 7 or 8 years and continue into adulthood, especially if there's a hormonal or a skincare issue. And up to 20% of people can develop severe acne and scars, which can be very hard to treat. The problem has to do with increased sebum production, of course, follicular hyperkeratinization. The role of bacteria and inflammation are, of course, well known. It's important for us to look for aggravating underlying factors, such as androgenic states, polycystic ovary disease being the most common by far, insulin resistance. In my practice, I see a lot of acne caused by excessive skincare. Also manual contact, compression make an issue, stress, and food is an issue. Most adults that come in with back acne, men usually have take-away supplements. Cow milk, sugar are also an issue. These are this is the list of treatments that I was taught in residency. Topicals, benzoyl peroxide, retinoids, long-term oral antibiotics. I gave hundreds of prescriptions of these. Oral isotretinoin, of course, hormonal treatments, and spironolactone. Frankly, in my practice, day to day, I've retained the first and the last. And I'll show you how. Of course, the problems with traditional acne treatments is that they're not always selective, they're not always highly efficacious, there are side effects, there is resistance, relapse, and often overlooked underlying causes. The concerns with oral antibiotics is that they take time to kick in, you need to keep patients on them. Dr. Mullen just spoke nicely about protecting the skin barrier. We have to also protect the gut barrier, and giving patients long-term antibiotics affects that and can cause significant issues with leaky gut and so on. Compliance is an issue. The systemic side effects of photosensitivity, as I said, GI issues, bacterial resistance worldwide, the relapse, and lifestyle constraints. Patients on tetracyclines have to avoid the sun, and that can be annoying for them. With isotretinoin, the common side effects, we all know them, we are the experts on them. Dryness, musculoskeletal symptoms, headaches, blurred vision, telogen effluvium, especially patients who have PCO. They usually have thinning hair. If there's a family history, give them isotretinoin, it gets worse. Teratogenicity, of course, is the most important thing with risk of abortion if it's taken during pregnancy, and severe birth defects. Depression, the controversy about suicidal ideation, mood changes. I know this sounds like a necrology text, but these are serious side effects that isotretinoin can cause, and we have to give it carefully. The GI effects, you all know of them. The need for monitoring, liver, lipids, need for contraception, the need for sun protection, and so many use cream for sun protection, which can aggravate their acne while they heal from it. The lifestyle limitations, and of course there is so much abuse, overuse, and the problem with self-medication in some countries. So the targeted therapies that I learned in my practice, the chemical peels, I find them very effective when there is a comedonal acne for the hyperkeratosis. Removing these comedones is essential. I'm surprised at how many colleagues do not do that and just give a prescription for isotretinoin. These are basic procedures that we should be doing in our clinic that relieve these patients when they have a predominantly comedonal acne or even partially comedonal acne. They should be removed in the clinic. I've used, being a laser person, I've used lasers, radiofrequency, topical PDT, and microneedling for a long time, starting in 2001, using the PDL to remove the marks, the inflammatory marks from acne, to using the smooth beam, which was a 1450 nanometer laser that was designed specifically for sebaceous hyperplasias and acne and large pores with good results. It was extremely painful and expensive, so it really didn't stand the test of time. We understood with time the importance of heat, and as you can see that much of the heat with many of what we use, for example, the thermage or the radio frequency, is at the level of the sebaceous glands. So it's interesting to use sometimes these devices, like I did in this patient here who had acne and cleared from it here after 6 months. These were like all off-label uses for these devices. And now we use more and more heat to modulate acne, and that's the kind of the end point, using the laser genesis technique or hitting those lesions with high energy gives a nice clinical, if you want, improvement of those patients. In my practice, it's like giving them a month of antibiotics. And when people come in with a red papule or cyst, I don't do ILK anymore, concerned with atrophy or so we usually hit them with these high energy devices and they get better. Until now, what we will discuss in a couple of minutes, I think the best thing that has worked in my practice for acne is topical PDT. Of course, using 5-aminolevulinic acid, which has good penetration into the oil glands, it has affinity for those, and then hitting the skin with blue light in this case, but it could be red light, or now currently using the ambient light, can in one session cause dramatic changes. This patient here, who actually happens to be our receptionist, who I showed you before, got better with the lasers that I gave her, but she continued to suffer. So I gave her topical treatment with topical PDT, and then a very short course of isotretinoin. And I can tell you that she still looks like this about 18 months later, as the picture on the right. Very nice clearing. So using lasers and energy-based devices for acne in my practice has been effective, but not extremely consistent. And of course, not a lot of studies to support all this, but the practice has been positive. Until a couple of years ago, when the 1726 nanometer laser, which shows selectivity for the absorption of sebum above water, was introduced. A big group at Harvard with Rox Anderson and his group and other groups have worked on that. And this is really a breakthrough in the field of acne. And there are today 2 devices, without, excuse the commercial names, but, they're facts. So we have a device that that's from Putera, and another device from a company that's called Accure. The same wavelength. One of them has a smaller spot size, another bigger spot size. I think the main important things is the way the cooling is delivered, because of course we need to provide high energy. One provides contact cooling, and the other one forces an air cooling system and keeps monitoring the temperature. And the one on the left would give you a single pulse, while the one on the right, the accurate laser, gives 6 pulses in an incremental pulses to give the heating that is required. So both take about 30 minutes to 1 hour to complete. Both were studied with 3 to 4 sessions and with nice follow-ups of 6 months to a year. But no studies in between the 2. We chose to acquire this device, which has the advantage of treating to temperature. So we have an endpoint, rather than just applying a handpiece on the skin and hoping that it would do an effect. Here, the system measures the temperature of the epidermis, which correlates with the glandular temperature. And the endpoint of the glandular temperature is about 62 degrees, which correlates with about 43 on the skin. So this is how it works. It gives a burst of pulses that peak eventually with pulse number 6 with the heat that needs to be generated. Let's see. So this is how it works. 6 pulses until the heat is deposited with the last one, as opposed to just giving it in one go with contact cooling. Both work. I'm not saying one works necessarily better than the other, but there are 2 approaches that you can choose from. So histologically, this is what you see. Using the Accure laser, you see the glandular damage with no damage around it, so showing you the selectivity at significantly more than 2 to 3 millimeters here depth, which is very important. This is the laser in action. We use a grid. The grid has squares of 11 or 13 millimeters, so depending on the case. I use it with my colleagues, Dr. Zainab and Dr. Ali, and we've already had it about 8 months. This is, I think, the main study to show you here, 35 subjects, mean age 26, up to 48, 70%. Skin types noticed up to 6, up to 4 monthly treatments, follow-up for a year. And what you want to look at is this, the inflammatory lesion count reduction at 52 weeks, which is so good, 90%. And there were no significant side effects with these treatments. These are also some tabulated results here, from different small studies. There are unfortunately no large studies yet. They're all studies of 20, 30 patients, but putting them together is coming up with numbers. And in fact, the pictures speak for themselves. Here's an example. So back to this slide. So up to 70 to 90% inflammatory lesion count reduction 6 months after 4 treatments. This is very important. 90% positive subjective satisfaction after 3 months. So who are the best candidates? Patients with moderate to severe acne who prefer a treatment in the clinic rather than take pills at home, patients who are not so compliant, patients who are medication phobic, who can't or who won't take it, patients who have low tolerance for any side effects, sometimes their moms or dads, history of acne recurrence, and those who want quality of life. Come in, get the treatment, get out with no restrictions. I'll show you pictures. You can review them everywhere. After 3 or 4 treatments, published by Dr. Brahimi, by others, by Dr. Rox Anderson and his team. Treatment done here in Dubai with a single session. Nice results. Results at 24 months, 35 months, Dr. Geronimus. So what side effects are we seeing? What are the challenges? The pain can be an issue. The company recommends using topical anesthesia.
2 minutes left.
Yeah, okay, I'm fine. Sometimes we need to use nerve blocks. Some people have really low pain threshold, and we've used Pronox for those. In about maybe 15% of patients, there's a small acne purge. It's probably a folliculitis from, maybe excessive damage to the oil gland that causes inflammation and folliculitis. It happens usually in the first or second session, just few acne lesions that go away on their own, and they respond to topicals. Of course, back acne is an issue because it can be too large to treat. The cost is hefty to us practitioners, and we have to pass it on to our patients, so it's not a walk in the park. And there is still a need for large studies to really document this on a very large scale. And it would be nice to do a study comparing to isotretinoin, and hopefully in the future there'll be insurance coverage. Our 8-month experience really has been a game changer in the clinic. It's nice that we have a treatment in the clinic that we can offer our patients that has an endpoint, which is the temperature, which means you're going to get that effect. So there is not much guessing. It's a treatment that gives 90% clearance in 4 sessions. Results last up to 3 years, if not more. No contraindications, convenient, and no lifestyle constraints. So my personal approach, and the team that we work together, we want really a treatment that is customized, that is efficacious, that is safe, convenience, not a knee-jerk treatment. We always look for underlying causes and address them. We treat them. We make sure all our patients stop their emollient skincare. It's so common, TikTok trends, Sephora, everybody's overusing, so we make them stop everything except the treatments that we give them. Dietary restriction, if there's a concern, peeling, cleaning when it's necessary. I still like to give aldactone when there is a hormonal issue, And you know, in my practice today, we use the NDAC for the inflammatory lesions, and I think the 1726 is really something that's huge that we will retain for the future. Thank you for your attention.
Thank you, Dr. Tuma. We're now welcoming Dr. Caterina Longo. She's an Italian board-certified dermatologist focused on diagnosis and treatment of skin cancer, paying attention to the study of melanoma and pigmented skin lesions with early identification through non-invasive methods such as dermoscopy, high-frequency ultrasound, and confocal microscopy for the in vivo and ex vivo study of cytological and architectural aspects of pigmented skin lesions in correlation with histopathology. So far, she published over 400 index papers on these topics and over 400 scientific outputs. The stage is yours, Doctor.
Thank you for the kind invitation, and today I'm going to change a little bit the topic that we had before. So we move into dermoscopy, and in these very few minutes I'm trying to get some highlights on what's new for some body sites. So first, we have some like 7 points. Starting with the lentigo maligna, we know well for definition for the book that we read that lentigo maligna is a flat, large in size patch in elderly patients. And we know that from a diagnostic point of view, we have challenging in the clinical discrimination, differential diagnosis in the dermoscopic definition, because you see here several flat pigmented patches on the face, but not all of them are lentigo maligna. And they are also difficult to diagnose for pathological point of view, because sometimes when you have just a small biopsy and not all the whole field of the tumor, our pathologists can be in trouble to get our reliable diagnosis. For lentigo maligna, that's a special body site because it's all about hair follicle here. It's like the scalp somehow. So all the criteria that has been described for lentigo maligna deal about the hair follicle shape, change, and morphology. And if you look in the literature, there are several descriptions that here it's a summary of that, the semicircle, the fine circle, the signet ring-like circle that I liked very much because these look like a diamond on a ring, okay? For example, the regular circle and the double circle, just to mention the ones that look for the early phase of the discrimination between lentigo maligna and other benign and non-melanoma tumors. So now what's the point? That's what we know already. But we know well that the majority of pigmented lesions on the head and neck are present in 90% of fair skin population. And plus, now we have a very common cosmetic concern. We would like to have a beautiful skin, and cosmetic procedures are increasing worldwide everywhere. And this is a kind of American spot. They said we want to age spotlessly, so with perfect skin. So we have an increased demand on getting procedure on the face, especially on the face. But the bad side is that we see, that's a study from New York, they said that the incidence of lentigo maligna that has been previously treated as a benign lesion was 7%. Okay, that's a number just for a study case for US, but it's a huge number, 7%, almost 8% of cases were regarded as benign and being instead lentigo maligna. So the point that we tried to understand last year is that, so if lentigo maligna by definition is a large flat patch in elderly, this means that if it's large, it should start small and should start earlier in the age. And so we focus to understand the features, the dermoscopic features of the young age group, equal or lower than 50 years old, also because that's the main population that wants to get aesthetic procedure. And that's the result of our multicentric studies. So we have patients even younger than 30 years old, and not surprisingly, we see that the size increases with the age. So meaning that in young population, we should look for small, tiny lesion. That looks obvious, but nobody told before. And not surprising also, with the age increase also the number of dermoscopic features that you find. So it means that when you look for a young patient to get cosmetic procedure, you have to look to tiny macule, and even one criteria is enough to do confocal or biopsy of the lesion before doing any laser. So the mean numbers of dermoscopic criteria per lesion in this young population was almost 3, and they were the symmetric follicular openings, and this is, in my view, the most difficult to recognize, but the most specific ones, and the others that we already know. Here are some examples that we have So this is a very young patient, and that's a little spot here. Look at the dermoscopy. I think that the clue, oh, sorry, because this here is, I don't know if you see clearly here, the little follicle and the little follicle there, just a little bit of the asymmetric halo around the follicle. That's enough to don't do laser on this lady or don't spray with cryotherapy, but instead we did confocal and then excision. That's another example. This lady told me, okay, I had it since many times. With dermoscopy, we focus on this portion, and we see here again some asymmetric pigmentation. But look, the lentigo maligna is all this area, but also that area here. So we are able also to detect here, you see these asymmetric follicular openings there. So it's really something that you have to catch. Also, men can have lentigo maligna in young age. And this man told me that this lesion was there since ever. And again, here we see striking features for lentigo maligna. But the point is that here we have the double circle. You see the double circle, the asymmetric gray color around the follicle. But also the other portion is lentigo maligna. So we get diagnosis and we can do the pre-surgical mapping. That's interesting story. He came for this lesion, okay, for confocal, and then I told him, okay, I do confocal on this lesion, and it was clearly a lentigo maligna, but also dermoscopically is nice to see the symmetry and the pigmentation. But then I had my patient in front of me, and I also looked here, and that's another lentigo maligna. This is called the zigzag pattern, you know, this kind of little rhomboid structures. And so this was like 2 lentigo maligna, or even 1, I don't know. I don't remember if we excised the entire 2 together. So 2 tumors at least. So this is just the papers that I mentioned, and here, you know, the overview of the cases. So 4, we do have any new lentigo maligna criteria. So we know how it looks like in young, and we want to know new criteria. And here, the most important paper of the last 2 years, the perifollicular linear projection. It's a rare finding. It was described by US friend. And here, what is going on here? That's the dermoscopy. You see the follicle with some streaks coming out from the follicles, corresponding to the nest in confocal. It's not an easy finding, but let me show you this case. Maybe you see better. You see this kind of projection getting out from the follicle. Also here, you see? Then it's a rare, but it's specific. So that's a case. You look at this lesion and it looks like a very large solar lentigo. And the patient said, I have several and I want to do a kind of resurfacing of my face. You see some damaged skin. And you look and maybe you see parallel fingerprinting or you think it's a real, but then you look and you see this very tiny projection also here on the top portion. That's enough. So it's a rare, but it's very specific. So that's what's going on for new criteria. 5, we have a Delphi consensus for the management of lentigo maligna, and not surprisingly, we agree that we should do dermoscopy in all suspicious lesions on the face. Regarding, we know that we have also extrafacial lentigo maligna. So lentigo maligna is regarded to arise on the face. And that's, you know, occurring the majority of some damaged skin, but also there is an extrafacial lentigo maligna, that is this one. It's a tumor that share histopathological feature with the lentigo maligna, but arise on some damaged skin, heavily some damaged skin, that we can see, you know, with the wrinkles, with a spot here, and usually they are large patch, really like the lentigo maligna on the face, quite solitary, slowly growing lentigo, and here you see again a kind of broken areas. Of course, here the follicles is not the main character, but you can tell that we have a kind of zigzag lines and gray color. And here, again, you know, the zigzag line, the typical pigment network, some kind of the ill-defined borders, some kind of criteria that can be found also with confocal for this tumor. So think about extrafacial lentigo maligna because they do exist. Point number 7, and then we try to conclude, nail melanoma. Nail melanoma, it's difficult for clinical diagnosis. It's painful to do biopsy, and also you know that when you do the biopsy of the nail matrix, you always have a nail that is destroyed forever because we do scar afterwards. That's the guy, one of the main guy for the nail melanoma, nail pigmentation. And we have a kind of flow chart to understand when the pigmentation is melanin or not. And then if it's one digit is more, of course, suspicious. And we have also some kind of schematic representation. The color is really important here. So when we see gray, it's okay. When we see brown, we should be more careful, because when it's gray, we have chance that there is here more than one digit involved, and that's the most common situation you can find, more than one digit. So always look, because sometimes it's subtle clinically, but you might find it only in dermoscopy. And that's the case of the lentigo, or of the ethnic pigmentation. This lady, you see clinically, you don't see many pigmentation, but then when you look with the dermoscopy, you see that we have a kind of grayish color all over the nail. Or drug-induced pigmentation. This is a lady that she did chemotherapy for a breast cancer, and you see the pigmentation that you have in more than one digit. So you have several reasons for having gray pigmentation on the nail. When it's brown, instead, here there are 2 points: the regularity of the lines and the size of the band. So melanoma, usually the width is larger, and if we look to the regularity of these lines here, you see granularity. You see here little granules corresponding to pagetoid cells. And here, this is another melanoma. You see variation for the thickness of the lines and also variation of colors. It's polychromatic usually. The thumb is the most affected finger, but also others can be. So melanoma, irregular lines. Also, this is a melanoma in situ. Irregular space and combination of brown and gray. And rarely you can also find this micro-Hutchinson. Actually, in my cases, I do not have. In fact, it's a case of Luc Thomas. It's a rare finding. When the tumor is more advanced, you see the destruction of the nail plate. So one digit with nail destruction, don't think about lichen planus, think about melanoma. And of course, here with dermoscopy, you see remnant of pigmentation here. That's a more obvious case, but it's still a pity that patient came with a late diagnosis. That's the Hutchinson sign, micro-Hutchinson sign. And here another case in which it's very common, at least in Italy where I live, where I work, to see elderly patient coming with this kind of nail, that it's an obvious melanoma, not only for the nail plate, but also for the surrounding. This lady thought that this was just a granuloma, pyogenic granuloma, but when we look, we see here the milky red areas, and we see pigment. Whenever you see pigment, it's always suspicious, and of course, what can be the destruction of the entire nail? So lastly, the 3 cases to conclude. Case number 1, case number 2, and case number 3. Case number 1, what it is? Hemorrhage, yes, exactly. With the hemorrhage, we see the purple, we see multiple colors, and of course, the hemorrhage grows with the nail. That's important. This is a boy, and that's the follow-up of the nail. It was 4 years. It's a pseudo-Hutchinson because he doesn't do, of course, the manicure, so it's just a kind of artifactual things. What it is? I cannot hear you because I'm getting a little bit old. It's a congenital nevus, right? Congenital nevus share the same features of melanoma, so the age is the only point that you can get. If I see the nail without knowing the age, well, I should think about melanoma. And during the follow-up, usually what happens is that progressively the nail becomes paler in color. So the history is always extremely important. This is another congenital nevus, extremely, with the Hutchinson sign, extremely worrisome. So for adulthood, either you have the photos of the nail when he was a young patient, or you should remove. If I see this in a patient and he told me that this lesion is there forever, I should have the photos of being a child with this, otherwise I don't trust my patient. And this, what is this? The easiest one. Nevus, exactly. Beautiful, lines are regular. Of course, since we don't see every day this kind of lesion, I always do follow-up for some years about the nail, and we are going to publish a paper in which digital follow-up for nail should be very long to be effective and don't miss a melanoma. So with that said, I try to conclude for nail melanoma. So the main features is that nevi are acquired during childhood, polydactyl, stable.
Just 1 minute, please.
And other reasons, whereas melanomas, it's usually monodactyly, changed over time, and with all the features that we saw. And this is a review in which you can find all what in this free access, so you can read in details, also other details that I didn't have time to go through. Thank you.
Thank you very much. We'll ask questions later after the last speaker. Thank you. So the next speaker is Dr. Ashraf Reda. He obtained his medical qualification in Ain Shams University, Cairo, Egypt in 1981, also served as a professor of dermatology at the same university. He spent 2 years in Mayo Clinic in Minnesota, where he got extra training in clinical dermatology, dermatopathology, and immunodermatology. He also published extensively and has several research and clinical articles in national and international journals, and actively participating in international meetings and presenting his work. Thank you. And your topic is atopic dermatitis, which biologic small molecule to choose and why, a practical approach. The stage is yours.
Good afternoon, everyone. Do you hear me well? Okay. Good afternoon, everyone. It's a pleasure for me to participate in the Regional Academy of Dermatology and Venereology this year. Over the next 15 minutes, which is very tight for a big subject, I will discuss biologics versus JAK inhibitors in the management of atopic dermatitis. So currently, we have 6 medications approved in UAE. 3 biologics and 3 JAK inhibitors. It's great to have so many medications in our hands, great for patients, great for us, because if one patient does not respond to one treatment, we can switch to the second or third until one of them will work. All the medication has the same label for approval, moderate to severe atopic dermatitis. So the label does not actually differentiate. This creates challenge. At the clinic, you have one patient, and you have to choose one of these 6 medications. The first step, which I will focus today, is should you give this patient biologic treatment, or you should give JAK inhibitors? So in this presentation, I will start with brief highlight of the difference of the mechanism of action between JAK and biologics, difference in all aspects, not only the mechanism of action. Then, practical consideration, how we really shortlist the patient to choose biologics or JAK. So we start with the differences between the 2 molecules. With regard to mechanism of action, there is a clear distinction. Biologics are precise. They inhibit specific cytokine signaling. They inhibit either interleukin-13 only or interleukin-4 and interleukin-13. So they are very specific. On the other hand, JAK inhibitors inhibit wide range of signaling pathways, interleukin-4, 13, 5, 22, 31, TSLP, all of these. This can be advantageous in atopic dermatitis because atopic dermatitis is not exclusively IL-4, IL-13s. More cytokines are involved. However, on the other hand, blocking many cytokines, some of them are not really important in atopic dermatitis, may result in side effects. We'll go to this later. Another difference is JAK inhibitors' efficacy and safety is dose-dependent. The higher the dose, the more efficacy and the more side effects. You don't notice this too much with biologic treatment. Biologics are large molecules. They are all subcutaneous injections, while JAK inhibitors are small molecules and given orally. So with regard to the onset of action, there is no doubt that JAK inhibitors has a faster onset of action. How fast? You would expect JAK inhibitors to work in 1 or 2 weeks. Actually, in some patients, it can be 1 or 2 days only. So this is, again, one advantage for some patients. Biologics require 4 to 6 to 8 weeks to give a good result. On the flip side, time to relapse. If you stop the treatment, biologics stay maybe more than 8 weeks. So if a patient missed 1 injection or 2 injections, still there is efficacy. While in JAK inhibitors, within less than 2 weeks, and in some cases, next day, the patient starts to itch as if they did not get any treatment. So one way advantage, one way disadvantage, this kind of short half-life, fast onset of action. With regard to the skin clearance, there are not many head-to-head studies between biologic and JAK inhibitors. Overall, over the short period of time, between 8 to 16 weeks, it is clearly that high-dose upadacitinib, 30 milligram, abrocitinib, 200 milligrams, have higher efficacy, higher skin clearance compared to all other medications. This is for the short term. Beyond 16 weeks, the difference becomes very narrow, if not disappeared. So this is just an example of abrocitinib 200 milligram versus dupilumab. At week 16, you find statistically significant more patients achieving EC90 and achieving 4 points reduction in itching, abrocitinib better than dupilumab. Then, at week 26, this difference is lost. There is no statistical significance. Another graph will show the difference between tralokinumab, dupilumab, and upadacitinib. This is not head-to-head study, just I presented for the sake of comparison. At week 16, again, high-dose upadacitinib have higher efficacy compared to tralo and the dupi. At week 32, the difference becomes narrower, and at week 52, very little difference, if any. So biologics, slow to work, we know that, but they may catch up after 6 months, for example. With regard to safety, biologics has no black box warning in the United States, while JAK inhibitors have 5 black box warning: infection, thrombosis, all-cause mortality, MACE, and malignancies. So this is important difference, although the rate of such side effects is quite low. We are talking here at the rate of 0.001, for example, or 0.002%, very low, especially if we are treating younger patients, healthy atopic dermatitis patients. However, because it is present, then we have to inform the patient and to discuss it. Other side effects, not the black box warning, with the biologics, mainly conjunctivitis and injection site reactions. There are few other reports with dupilumab, such as arthralgia, cutaneous T-cell lymphoma, or psoriasiform reactions, few cases. JAK inhibitors have more risk of side effects. It could be acne, it could be nausea, vomiting, it could be increased herpes infection, it could be blood changes, lipid or liver enzymes, for examples. Monitoring is not required for biologics. No pre-treatment monitoring, no regular monitoring throughout the treatment, which is very assuring to the patients. JAK inhibitors require a set of pre-treatment investigation, like tuberculosis, like hepatitis profile, lipid and full blood count, and kidney, and then regular monitoring throughout the treatment. Drug-drug interaction, no significant drug-drug interaction with biologics, but quite few drug-drug interactions with JAK inhibitors. You need to review all the medication the patient is taking before prescribing JAK inhibitors and to run a drug-drug interaction checker to see if there is interaction or not. Pregnancy and breastfeeding is absolutely contraindicated during JAK inhibitors, while in biologics, preferably not like all medication, but still in selected cases, severe cases, patients can continue on the biologic until week 30, because in the first 2 trimesters, IgG do not cross the placenta. So these are the main difference between them. Now, in the clinical practice, you have 1 patient, and you have 6 medications. You need to choose the medication. How we can do that? First, look at the patient age, of course. All 6 medications approved from the age of 12 years. Only dupilumab and baricitinib approved from the age of 2 years and above. And only Dupixent or dupilumab approved from the age of 6 months. So depending on your patient's age, you will choose one medication, or you still have the 6 available for the patient. If the patient in childbearing period, preferable to use biological treatment unless the patient is willing to use contraception throughout the treatment. If a patient has severe comorbidities, multiple medications, these patients usually have higher risk of side effects from JAK inhibitors, so biologic would be preferable. Also, biologic is preferred in elderly above the age of 65 according to the EMA indications. Patients who have higher chance of risk from JAK inhibitors better to go for biological treatment, such as increased risk of major cardiovascular disease, smokers, past smoker or current smokers, especially if they are heavy smoking, increased risk of cancer as well. Patients with recurrent infections, again, have higher risk of side effects from JAK, so it's better to go for biological treatment. And if a patient has atopic dermatitis, plus one of these approved indication for dupilumab, it's better to use dupilumab because it will work on both diseases. Patients who has continuous eczema with flare, so it is not episodic or seasonal, they require long-term treatment, and biologics are very good for long-term management, not for short-term management. So I have listed quite few scenarios where biologics is preferred compared to JAK inhibitors. This doesn't mean that JAK inhibitors are second lines. There are some cases in which JAK inhibitors can be a very good first-line option. For example, to get benefit of the high efficacy, quick onset of action, JAK inhibitors may be preferred in patients with very severe disease. Also, patients who want rapid onset of action for whatever reasons, they have trip, they are going to get married, whatever, this is a good option for them. Patients who have episodic or seasonal atopic dermatitis, they don't need continuous control of atopic dermatitis, maybe 3-4 flares per year. We can control those flares with 1 or 2 months of JAK inhibitors. Patients who do not want needles, patient with high risk of developing conjunctivitis, patient who failed the biologic treatment as well. So these are preferred for JAK inhibitors. Also, a patient with atopic dermatitis with comorbidities of any of these approved conditions for upadacitinib, it's better to use both, to use upadacitinib in such case to cover both conditions. So these are the general differences between the biologic and JAK, and when biologic is preferred, when JAK is preferred. Despite all these differences, you will find that many patients can still take biologic or JAK. There is no contraindication, so they can fit for there. Here, shared decision-making is the way to go. We have to explain to the patient the difference in efficacy, safety, process, is it oral or injection every 2 weeks or every 4 weeks, and the cost, because many insurance companies now put co-payment on the patient, and these are expensive medications. So 20% co-payment with an expensive medication may not be affordable by the patient. So keep in mind the out-of-pocket or the co-payment the patient has to pay. And then the patient with the dermatologist should decide the best treatment. In summary, we have 6 medications, 3 biologics, 3 JAK inhibitors for moderate to severe atopic dermatitis. They have different mechanism of action, could be beneficial to be very precise, or could be beneficial to have multiple cytokines. It depends on the case. These are the main clinical differences between them. Biologics are safer, well suited for long-term treatment. They have longer time to relapse, and they are injections, not Many people like injection, but it's actually better for compliance. While JAK inhibitors has faster onset of action, higher short-term efficacy, and they are oral, which is convenient for many patients. These are the main differentiation in clinical practice. Shared decision-making is very important. These are serious medications, and the patient has to understand the medication and to have a say on which medication they are using. Thank you very much.
Thank you, Dr. Ashraf, for an excellent talk. Please join us for the questions time. I would like to ask all the speakers to join us on the stage, and we'll open only one question for each speaker because we have a limitation of the time. And we have one more session to go before our lunch break. Dr. Hussein Abdeldaim, the question to whom?
Thank you for all the speakers, for Dr. Sonia, for diglucitinib. She's not here. Okay.
Dr. Moline, Dr. Moline.
Dr. Moline. Okay, so any other one who has question for any one of the speakers who are available? And my question for Dr. Moline, anyone has any question for the other three speakers?
Any other questions for the speakers? Yes.
I've got a question. Dr. Dani, I want to ask, what is your view, now in more data coming up, that, more and more questions coming up, research coming up that we have isotretinoin and lasers at the same time are safe. What is your view?
Look, I think combination therapy is always a good idea. It allows to reduce the dose of 2 or 3 interventions and give better results. In fact, I showed a case of topical PDT. In that case, I thought that she would have needed a second course of it, but we chose to give her a low dose of 20 milligram of isotretinoin for only 3 months, and she's cleared it very nicely. So combination is very nice. My personal bias is to try to avoid isotretinoin as often as possible, but of course, reducing the dose is going to be much better than giving the high doses. And if we are able to use lasers or other devices to give patients shorter courses of lower doses, I think it's going to be golden.
Thank you. Any other questions from the audience? If there's nothing, we would like to thank all the speakers